Hey, this is the second lecture I ever made. It was when I was a resident. It's anatomy of the cervical spine. I went through a lot of different texts and anatomy from different books, whether they be neurosurgical, physiatric, and even review articles. Again, second lecture, so there's a lot of animations here. And one of my co-residents realized that, yes, I did create the art in the back. That's C2, and it's sort of like a nod to the Matrix as a background. So, the cervical spine is a complex and vital region, and there's a lot of stuff in the neck, all right next to each other. And so complete familiarity is important if you're going to be doing anything related to the neck, especially injections or surgery. But I think it's just good for physiatrists to know the anatomy of the neck. So we're going to cover bony stuff, then ligaments, then discs and endplate, then neuroanatomy, and then muscles. We also will touch on the vessels. So I think when talking about the bony stuff, it's good to break it down into the vertebrae, which the interesting ones are C1, C2, and C7. C3 through 6 are kind of the same, so you can kind of look at them as one structure. Then there are these complexes. There's the Atlanto-Occipital Complex, the Atlanto-Axial Complex. Then we have the joints, which are basically the Facet Joints and the Uncovertebral joints, or joints of Lushka. So each textbook initiated their discussion of the cervical spine by mentioning that there are 7 cervical vertebrae. However, the authors presented varied ways of organizing them. First, you can look at it anatomically in terms of typical C3 through 6 versus the atypical C1, 2, and 7, like I said in the other slide. And that's what the orthopedic text did. The physiatric text breaks them down functionally into upper, C1, 2, and lower, C3 through 7 regions, while the neurosurgeons use a slightly nebulous compromise. So clearly there are distinct anatomical and functional differences which make it worth considering both systems. So we're going to discuss the anatomical differences using the orthopedic system and address the functional issues using the physiatric approach. So let's take a look at the whole spine here. If you look, let me get this going here. If you look here at the cervical spine, it does have a lordosis. The thoracic spine has a kyphosis. The lumbar spine again has a lordosis, and then the sacrum has a kyphosis. So the whole thing kind of like adds up to 0 if you were adding up angles. If we look also, you'll see that it's widest here at the cervical spine, in the whole spine. The vertebrae are relatively smaller than the ones in the lumbar spine. And up here you can see that we have bifid spinous processes versus just the singular process on the thoracic and lumbar. So let's zoom in a little bit here. You can really see how big C1 is compared to the rest of the spine, and the bifid spinous processes, and the cervical curvature, which is a lordosis. So actually, just know that I am going to repeat things over and over and over again, because repetition is the way to learn. Review, review, review. So vertebrae at first look can be very complicated looking. This is from Gray's Anatomy. And I'm going to take this and make you understand it schematically so that you could actually draw it yourself. Now, remember, this is done when this was my second lecture. So you're going to see, as a second lecture, you're going to see that I didn't really know how to do things super technologically proficiently. So it's going to look like a 4-year-old did it. But what I'd like you to do is take a piece of paper and draw each of these components and memorize how to draw them. So the first is the vertebral body. So you're going to just draw an oval, and we're looking down on it, just like we did in the Gray's Anatomy picture. Then you're going to have two rectangles coming backward, and those are the pedicles. We're going to go into detail about all of these. Next, you're going to draw these big circles, which are going to be your lateral masses. Again, we'll talk about these later. Then you're going to have two lines coming back from there, connecting to each other, and those are going to be the laminae. And then, this is trifid, but you want to draw two, a bifid spinous process. Then connecting to the pedicle, and it's very important that it connects to the pedicle. This thing that looks like a mustache is actually the transverse process, which also gets called the posterior tubercle, but I want you to think of it as the transverse process. Then just in front of it, the red one here is the rudimentary rib, which, this is where the rib would be if it were a thoracic spine. But in the cervical spine, obviously we don't need ribs. So this is the one in red. Now you're going to connect these with a line, and that is your costotransverse bar. That makes sense, right? The transverse process, the costal element, connect them, and that becomes the costotransverse bar. So yes, it's ugly, but it's correct. If you look here, you've got your vertebral body, then you've got your pedicle, and then somewhere in this mush here is that transverse process. Here you have the rudimentary rib connected by bone that creates this foramen. And you can see the foramen here too. Here is the lateral mass, the lamina, and then that creates the bifid spinous process. So there you go. Now let's get into these in detail. So I think it's good to look at the C3 through 6 as one structure because they are all very similar. So first you'll notice that there's a front and a back. The front is the vertebral body or anterior segment, and the posterior segment, also sometimes known as the posterior arch, is the two pedicles and the two laminae. This gives you basically the back here. And these support 4 articular processes, 2 transverse processes, and 1 spinous process. So let's look at it from Netter. There's the vertebral body. There's the rudimentary rib element, which is also called the anterior tubercle. That's the posterior tubercle or the true transverse process. There's the costotransverse lamella or costotransverse bar. There's your pedicle. There's your lateral mass, lamina, and the bifid spinous process. So let's look at each of these into detail now. So looking at the vertebral body in detail, it's small in comparison to the other regions of the spine. It's the primary load-bearing element. It actually takes on 80 to 90% of the weight. It's basically surrounded by cortical bone, which is much denser, and then it's got cancellous bone inside. Its longest dimension is in the coronal plane. It has a side-to-side convexity. I'm going to show you what this looks like. And in the front to back, it's actually got a concavity with an anterior lip overlapping the vertebra below at times. And the posterior aspect is perforated by multiple vascular foramina for passage of basovertebral veins. My buddy Jim McLean, during residency, said, "Oh, so with the convexity and concavity, it's basically like a Pringle." Pringle is a type of chip, if you're not aware. And yes, that's, I think, a reasonable way to think about it. So let's look at the posterior tubercle. That is a true transverse process, unlike the anterior tubercle. It has a foramen, unlike the thoracic and lumbar spine. The anterior tubercle is actually a rudimentary rib element. Like I said, in the thoracic spine, you would have a rib there. And it arises from the side of the vertebral body. At C6, it's sometimes known as the carotid tubercle or Chassenac's tubercle. The costotransverse bar, or costotransverse lamella, unites the tubercles to form the most lateral aspect of the intervertebral foramen. And then medially, it's the pedicle. So let's look at the pedicles. These project posterior laterally from the vertebral bodies, and the angle progresses. There are notches on the superior and inferior surfaces, and that's what contributes to your neuroforamen. And yeah, there it is. The lateral masses, really in this picture, I like it. It's from Netter, and you really see the massiveness of the lateral masses in this as it compares to the vertebral body. They form at the junction of the pedicles and laminae, which you saw in the drawing that I made you do. And it gives rise to the superior and inferior articular processes, or facets. So here's the superior facet of one, here's the superior facet of one, and here's the inferior facet of the other. Two of them combine to form the facet joint. The laminae are just big hunks of plates of bone that come back together to form the spinous process. And the spinous process itself, bifid, like I said, C3 through 6, it lengthens the moment arm for muscles to attach. And at C7, it's the longest one, and it's easily palpable, and that's what most of us use for surface anatomy to orient ourselves, to figure out where we are in the neck. So let's talk about C7. It's also known as Vertebra Prominens, beautiful name. And as you can see here, it's not quite the same look as the cervical spine. And if you looked at the thoracic spine, it doesn't look like that either. I think of it as sort of the inflection point. So it looks like both of them. It's the transition from cervical lordosis to thoracic kyphosis, and you can palpate it. And the costal component of the transverse process could be very well developed, and we call that a cervical rib. So now we move on to C1. C1 is known as Atlas, and Atlas was a titan in mythology, and it's come to mean he who dares or suffers. He was the son of Poseidon, and he ruled Atlantis, and Zeus, when he banished all the titans, made Atlas hold the skies and heavens up. That's why he's seen as holding up the earth. And he tried to trick Hercules into holding the earth, but then Hercules tricked him back. And then finally, Perseus turned him into stone and turned him into the mountain. But in anatomy, C1 is the atlas, and you'll see that it has no obvious vertebral body. Embryologically, what would be the body is actually contributed to C2. And so it's essentially a ring without a vertebral body. And as we saw in the other pictures, it's the widest vertebra. It has two big lateral masses, and that's for shouldering the weight of the skull, which I'm going to show you a little later. It's got an anterior arch, thick anterior. Let's get to this. It's got a thick anterior arch here, and it's got this long, thinner posterior arch. But you can see how it's analogous to the other vertebrae. It has an anterior and posterior tubercle, which is a little bit different. And you can see the kidney-shaped articulations over here. And that's for articulation with the skull. Looking at it from the bottom, you'll see that it's notched on the bottom so that it can form the C2 intervertebral foramen below it. A couple of other points here. It doesn't have a spinous process, and it doesn't have a rib element like the other ones do. So C2 is axis, and kind of makes sense because this is where all the rotation occurs. It has an upward projecting odontoid process, or dens, which articulates with the posterior aspect of the front of atlas. It's got some thick laminae, big lateral masses, bifid spinous process like the C3 through 6, and C2 exits posterior to, right over here, posterior to the superior articular facet, It's the strongest of all of the cervical vertebrae, and the dens I already told you about. And, dens goes all the way up into actually foramen magnum, and it's held kind of in the front toward the atlas by some ligaments, which we'll talk about later. So now we can move on to the Atlanto-Occipital Complex. Basically, the atlas is holding up the skull, and the lateral thickness of the joint capsule restricts lateral bending. The anterior membrane limits extension, and the posterior one limits flexion. And this is a picture of my father, who was a psychiatrist, but back in India they used to do, I think, like 2 whole years of anatomy. Anyway, he said that you have to think of the orientation of the atlas condyles this way, just like holding up a ball like this. So that might help you remember how the Atlanto-Occipital Complex is oriented. Let's move on lower to the Atlanto-Axial Complex, which is 3 joints, which is basically the 2 facet joints on the side, and then the actual axis of rotation, the median pivot joint. This actually has a synovial membrane and capsular ligaments. It articulates with the odontoid of the axis, allowing about 45 degrees of rotation in either direction, and there are a few degrees of flexion and extension. A board question every year is what instability, what amount of millimeters of separation is considered instability, and you're going to have to look up what the latest numbers are, but it used to be greater than 3 millimeters of separation when I made this lecture. This can be due to trauma or rheumatoid arthritis, or even in people with laxity, such as with Down syndrome. So we've talked about the vertebrae, we've talked about the complexes. Let's actually talk about what the spinal canal is. It's the sequential stacking of vertebral foramens that forms the big canal. And it's enclosed by the vertebral body anteriorly, and then the vertebral arch, which is basically here, the pedicles and laminae. This is what the posterior part is. And it houses the spinal cord and the meninges. It's widest at C2 and smallest at C7. And at C2, the anterior third is occupied by the odontoid peg. So functional considerations. The cervical spine is a discrete, and it's the most mobile part of the axial skeleton. It has an inherent curvature of a lordosis. It serves 3 major functions, and any of these being affected is going to affect the rest of it. It supports and provides stability for the head. It enables movement in all planes of motion, and it protects all the passing structures that are within it. More functional considerations. Anatomical differences in the shape of the articulating joints as we move from the upper to the lower cervical spine. Basically, the upper part is all about rotation, and the lower part is about flexion, extension, and lateral bending. Instability is noted if horizontal displacement of greater than 3.5 millimeters, as we had said in the Atlanto-Occipital joint. Any angular deformity of greater than 11 degrees. All motions are coupled, and the idea is that if you can understand how the C-spine works anatomically and biomechanically, it might help clinically. So now let's move on to the joints. The zygapophyseal joints have many names. They can be called the Z-joints, the posterior joints, the joints of the vertebral arches. Facet joints is a very common one, and apophyseal joints. I think you're going to hear zygapophyseal and facet joints the most. So let's get this figured out. So here is the facet joint right here. It's the articular interaction between the superior and inferior articular processes. So let's look a little bit more closely at the zygapophyseal joint or facet joint. Here we see it without its capsule, and then up here you see the they've been encapsulated. So the first thing is that the nerve roots pass anteriorly. You can see them here. The nerve roots are passing anteriorly. And so what that means is that if there's any problem with the zygapophyseal joint or facet joint, then that could relate to a nerve root problem. They're surrounded by a soft tissue joint capsule, and they receive innervation from the medial branches of the dorsal rami. And as I said, osteophytes can compress nerve roots if they're there. So this slide gets a little deeper than we need to, and it's also, unfortunately, a picture from Netter's of the thoracic facet joint. But some little bits of minutia that came from looking up anatomical papers. Basically, you can have a meniscus or you can have a synovial membrane in any of these joints. But the main point is that it's providing a fail-safe locking mechanism against motion forward and backward. So this shows you how the oblique orientation of the Z joints try to affect rotation and lateral flexion. So this here is the lumbar spine, which is the opposite. Here's another view of the facet joints. If you look over here, very easy to see the inferior articular facet and the superior articular facet articulating to create the facet joint. Here are the facet joints in the AP view. And the intervertebral foramina are just anterior, as we said, and now we're going to talk about them. The intervertebral foramen is formed by the confluence of the vertebral structures. Superior and inferiorly, it's the pedicles of adjacent vertebrae, and posteriorly, it's the facet joint. Anteriorly, it's the uncovertebral joints, the disc, and the inferior vertebral endplate, and we're going to look at that in a moment. Inside the intervertebral foramen are the dorsal root ganglion, the ventral root, the sinuvertebral nerve, and the vertebral vessels. So let's talk about the uncovertebral joints. First, you need to understand what the word uncus means. Uncus just means hook, and it's the posterior lateral margins of the superior surfaces of the lower 5 vertebrae, which raise up into lips to form those uncinate processes, or uncus, and they project upward toward the vertebrae above them. So here you can see the uncus up here, and here down below you can see the encanture. This is the location of where this is going to articulate with the vertebra above. So this later can develop articular cartilage and synovium, capsular ligaments, and a joint space, although for your boards, it's not a true joint. It may limit lateral translation, and nerve roots pass posterior to it, which is why you can get radiculopathy by nerve roots being compressed by uncovertebral hypertrophy. They're also known as the joints of Lushka or neurocentral joints. We don't see them at birth. In the first or second decade of life, the same degenerative process that occurs in your 5th decade occurs in your first or second decade of life to create these uncovertebral joints. And they have the same histologic appearance as the annulus fibrosus, suggesting that maybe these come from the same embryonic cells. Lushka was the guy who, determined that this anatomy existed, and this is the paper that he published. He said that it acts as a barrier to the extrusion of disc material posterolaterally, preventing compression of exiting nerve roots. And it may allow the cervical disc a larger amount of freedom of movement because it's being contained within by it. This is a picture of it from a neurosurgical book, and I really love the way the uncus is obvious here, and the uncovertebral joint or joint of Lushka is here, and you can see how the disc is maintained within there. But if there were any degeneration here, it would probably cause compression of the nerve root as it comes out here. Here's another neurosurgical text showing the joint of Lushka. Here they're talking about the analogy between the uncovertebral joint and the costovertebral joints in the thoracic spine. Here's another one from a neurosurgical book talking about biomechanics. Looks like we're moving on to intervertebral disks. This is from a neurosurgery book again, talking about how archetypical anatomy would be that there's a horizontal and vertical axes, but in the human cervical disc, it's actually at diagonals. So intervertebral discs are fibrocartilaginous joints. They are the shock absorbers or cushions between the borders of adjacent vertebrae, and they provide for some movement. They separate the vertebral bodies to give enough height to the intervertebral foramen. As the disc gets degenerated, the intervertebral foramen gets smaller as well. C2-3 is the most cephalad disc. There's nothing between C1 and C2, as I discussed already. They are biconvex to accommodate the concavity of the vertebral bodies. They contribute to the lordosis, and the border between the annulus and the nucleus becomes less distinguishable with age and degeneration. It's avascular and nourished by alternate compression and refraction. So the annulus fibrosis is, believe it or not, mostly water, but the dry weight is mostly type 1 collagen. It's 10 to 20 spirally arranged layered laminae of collagen bundles. So by doing it this way, the fibers being arranged at right angles, it makes it stronger, and they connect with the different ligaments in the front and the back. The nucleus pulposus, I have this picture of a jelly donut because I tell my patients that it's kind of like the jelly inside of a jelly donut. It's a semi-gelatinous central portion, eccentrically located a little closer to the front, and it's contained by the annulus and the end plate. It contains type 2 collagen fibers, has a lot more water than the annulus does. Just showing you that there can be compression of the disc, and it's normal. Here we see images from the original paper discussing the sinuvertebral nerve. The sinuvertebral nerve is what innervates the disc, the periphery of the disc. Here, I guess we're repeating our discussion of the uncovertebral joint. So let's move on to the end plate. The end plate are the superior and inferior portions of the intervertebral discs. And there's both a bony end plate and a cartilaginous end plate. So the bony end plate is part of the vertebra, and the cartilaginous end plate is a different structure, which is composed of both hyaline and fibrocartilage. This is from Dumitru, and it's just showing that the entire nucleus pulposus and approximately the inner third of the annulus are contained within the end plate, both superiorly and inferiorly, and it may have some role in nutrition of the disc and growth of the vertebral body. Let's move on to the ligaments. In general, they provide strength and stability. The anterior and the posterior longitudinal ligaments, you remember from med school, they offer a kind of front and back stability. Flexion stability is maintained by the facet capsule ligaments, the supraspinous ligaments, and the interspinous ligaments, and the ligamentum flavum, which we'll talk about. The occipitovertebral ligaments are important, mainly the transverse ligament of the odontoid. That's the one that keeps it from moving forward or back and causing instability. I love this picture, and I love this picture as well. And these are the different ones: the apical, tectorial, posterior, and anterior Atlanto-Occipital ligaments. These are from Netter, essentially showing you the same thing. I like this one right here. Oh, let's get this. I like this one right here, as it shows you the transverse ligament over here of the atlas. As you can imagine, if this gets messed up, this is going to come posteriorly, and you're going to see that on MRI. More ligamentous anatomy. And here we can see the difference between a quadruped and a biped looking backward. The anterior longitudinal ligament, tightly adherent to the front of the vertebral bodies and loosely blends with each annulus as it crosses the disc spaces, and it provides stability during flexion, resisting extension. The posterior longitudinal ligament is essentially the opposite. There is a venous plexus between the posterior longitudinal ligament layers, and I think this is important for those of you who are going to be sticking needles in people's backs. The ligamentum nuchae is probably what we're palpating as we palpate the cervical spinous processes. The ligamentum flavum is really important to understand. It's very strong and elastic, and it connects one lamina to the next. But there's lots of discontinuity in the ligamentum flavum, and this is what gets penetrated when interventional spine doctors are sticking needles into the cervical spine, but it does prevent excessive motion, and it's an essential in the role of the loss of resistance technique, which I don't think anyone's using anymore. But basically, as they're injecting the needle, as they're inserting the needle through the cervical soft tissue, they're also putting pressure on the syringe. And once they lose resistance, that's when it moves. The idea is that you've passed through the ligamentum flavum. Another picture of the ligamentum flavum from Netter. There's stretch under tension, and it retracts without undue bulging or folding in a normal state. It has a high content of elastic tissue, and flexion obviously will stretch it. Due to its elasticity, it returns to its original configuration in neutral. It doesn't fold on itself to compress the dura. There are these intertransverse ligaments. This is, I think, from Dimitru again. And there's a lot of, this may not be getting as much attention in your regular anatomy course. But I do think it's important for those of you who are going to be sticking needles again. The Transverso-Articulare Ligaments as well. In the cervical and lumbar regions, they cover the medial branch of the dorsal primary ramus, which is important for medial branch blocks. The transforaminal ligaments span the exterior of the intervertebral foramen. And is it a true ligament? There's a number of muscles in the cervical spine which are important to go over, and I don't go into detail about these. These are things that you should look up, understand, and get some general sense of where they are. Obviously, trapezius is a really important one to know. The splenius, the longus colli, these are important ones. And the multifidi are really important because that's the one you're sticking the needle in when you're doing your EMGs. And it's the one that your physical therapists are targeting when they're doing cervical stabilization. Some pictures. These are the force diagrams of those muscles. Love these. These are our rotatories or multifidus muscles. Neural structures that you should be familiar with include the spinal cord, the nerve roots, the rootlets that comprise the roots, the dorsal root ganglion, the spinal nerves, the sinuvertebral nerve, the meninges, and the autonomics. So this picture from the from a neurosurgery textbook again shows the spinal cord, and you really should already kind of understand gray matter versus white matter. There's usually a central canal, and the dorsal root entry zone and the anterior root exit zones are discussed in, again, neurosurgery anatomy books, but I haven't seen it really come up in physiatric contexts. The nerve rootlets, as you can see here, coalesce to form the dorsal root, which then becomes the dorsal root ganglion. The ventral rootlets come together to form the ventral root, which then joins the dorsal root ganglion. So the nerve roots and dorsal root ganglion. The ventral efferent root and a thicker dorsal afferent root exit at every level except C1. They are particularly vulnerable to mechanical injury for multiple reasons, and the roots distally are encased by a rigid nerve root sleeve, which eventually is consistent with the continuous with the epineurium. The dorsal root ganglion contains the cell bodies of all the dorsal root axons, and in one anatomical study, it's funny, approximately 30% of the ventral root's axons. I asked Dr. Goldstein about this. This was actually in his paper. The dorsal root ganglion has also demonstrated mechanosensitivity that is especially seen with chronic injury, and the dorsal root ganglion and sensory nerve root are major players in radiculopathies. More pictures. More pictures. I guess we're talking about the meninges now. The dura mater is the one that is thickest and in the periphery of the spinal canal. Here you can see the dura, the subdural space. Outside of the dura would be the epidural space, which is mostly fat. The spinal nerves are just beyond the intervertebral foramen and divide into ventral and dorsal primary rami. The C1 dorsal ramus does not have a cutaneous component. C2 has a large dorsal ramus, and the medial branch is known as the greater occipital nerve, and this is very often targeted for injection. The principal branch off the C3 dorsal ramus is the third occipital nerve, or TON, which supplies the C2-3 Z joint, or facet joint. And so that's a target of interventional spine doctors as well. The cervical ventral rami from the cervical and brachial plexuses innervate the periphery, and the cervical plexus is also important in innervating the diaphragm. C3, 4, 5 keeps the diaphragm alive. The spinal nerves branch into ventral and dorsal rami. The dorsal rami divide into lateral and medial branches, where the lateral branches go superficial and innervate the superficial muscles and the skin over the back. The medial branches go deeper, and they innervate the deep muscles, facet joints, and even the discs. So the sinuvertebral nerve is really important because it innervates the deep structures, specifically the periphery of the disc. And it gets contributions from the sympathetic trunk as well as the anterior ramus of the spinal nerve. It innervates the posterior longitudinal ligament, the periosteum, and the disc. It runs back through the intervertebral foramen. It's weird. It goes out and then it comes back. Anterior to the spinal nerve, posterior to the vertebral artery, and arrives at the posterior aspect of the disc and posterior vertebral body. It branches off to the lateral edge of the posterior longitudinal ligament. C3's sinuvertebral nerve goes upward into the cranial fossa and supplies the dura of the clivus. The dura mater is the dense fibrous tube that extends from the brain down into the spinal cord. It contributes to the nerve root sheaths, and then past the dorsal root ganglion, it got direct continuity with the epineurium. The subdural space is a potential space between the dura and the arachnoid. It's richly innervated by the sinuvertebral nerves, which we already covered, and it's got particularly mechanochemically sensitive over the ventral aspect of the thecal sac, which makes sense. You would want to know if there's anything going on there. So the leptomeninges include the arachnoid and the pia. The autonomics in the neck include pseudomotor, pilomotor, vasomotor, etc. I thought it was also important to share that there are a superior, middle, and inferior cervical ganglion, and these can be sites of injection as well. The cervical vertebral vessels include the internal vertebral venous plexus and the vertebral arteries. The venous plexus is best visualized in netters. Here you can see it. The vertebral arteries course upward through the transverse foramens that we identified in the osseous part of this lecture, and the anterior borders, they sit in the anterior borders of the neural foramina. So the vertebral arteries, being that they're in these foraminae, is going to be moving along with movement of the spine, which is fine, except when deformity has occurred and there's tortuosity or compression of the artery or its branches, and at that point that can lead to syncope. Clinically, I haven't been able to identify this particularly, but it is something to keep in mind. The cervical vessels are important to keeping the spinal cord functional. And here I'm just basically saying, look, there's various sources for pain generation, and I think it's important to know the anatomy in order to realize that there's so many different things that can cause that kind of pain emanating from the cervical spine. This slide is just showing you that the cervical spine is a small part of the neck, but the neck just has a lot of structures in there. So if you're going to be sticking needles in someone's neck, just make sure you know all this anatomy. Not too intimidating, huh? I hope you've found some benefit from this. I encourage you to freeze the slides and try and understand all the anatomy before moving on to the next slide. Have a good one.